Hello, I'm Dr. Chad Vercio. I'm the chair of pediatrics here at RUHS and the host for the webinar. Happy to have you here with us today. And we have two experts in a field that is becoming coming to the forefront of medicine, which is looking at the social and other kinds of environments that other kinds of factors that can influence the health of our patients. And so we have Dr. Jeff Leung, who is our medical director for the community health centers here at RUHS, and has helped in the development of the whole person health score. And then we have Dr. Ariane Mitchell, who is also affiliated with RUHS in Loma Linda. And I've worked in the past on the development of the whole child assessment. I have to give her pretty much all of the credit here. She did pretty much all of the work. I happen to be the medical director at the clinic that was originally piloted and developed in. And so happy to have them both here to discuss these topics or these ways of assessing the social needs and resources of our patients and how that can drive and improve their healthcare and build a relationship between the provider and the patient or family. So I'm going to turn it over to Dr. Leung first, if he is ready to go here. And so he's going to speak with us on the whole person health score.
Thank you, Dr. Vercio. And if it's okay, I'll borrow the screen and then you can help move me along if I'm taking too long. But just to give a little bit of background, we know there's a lot more interest in looking at health holistically right now. We have, well recognized that health is more than physical and that there are other components, including things like emotional health and socioeconomics, that actually contribute to how long and how well people live. Historically, we've focused on physical health measures, and we know that things like blood pressure and smoking can have a very significant impact on our expected lifespan. Blood pressure that is poor can take 15 years off of your expected life expectancy, and smoking, similarly 6 to 10 years. But what we haven't recognized as well, at least from a healthcare model, is how we have a number of other determinants that can have an equal or greater impact on how long and how well we live. So whether it's depression, education level, finance, homelessness, the level of social support that we might have, substance abuse and addiction. All of these things can have a dramatic impact on our lives as well, and we don't really take that into account when we measure things in healthcare. So the whole person health score is this concept where we use a 6-letter score, and each letter represents a different dimension of health. The first letter represents physical health, the second one emotional health, then resource utilization, socioeconomics, ownership and activation, and nutrition and lifestyle. And the first letter of each category spells out the word person. So we also call it a person score. Each letter can range from A to Z, with A being the best and Z being the worst. And, our hope is that, with a short assessment, that sort of then populates the score, that even at the beginning of an encounter or a clinic visit, we have a good sense of, maybe a good global sense of where a patient is. So for instance, this is a 52-year-old gentleman with uncontrolled diabetes. And in his case, if we knew up front that his whole person health score was GSA, WCL, just using that scoring mechanism. And remember again, A is worse than Z. Z is sort of the worst. And you can see in this example that the patient sort of scores the lowest in areas like socioeconomics and emotional health. And by having that information up front, would it change how we sort of negotiate and prioritize time and activities during that 15 or 20-minute clinic visit? And in this case, it might, maybe instead of just talking about medications, we might also talk about, housing situation or job situation, or connect this patient with a therapist. So again, the tool itself is based upon a 28-question assessment, and each of the elements for those questions represents an element that we, have found can be related to how long people live. This is an example of those elements. So it includes everything from traditional measures like blood pressure and body mass index to, emotional measures like depression and anxiety. But, it also includes some, less common elements such as looking at meaning or purpose or social support, self-rating of health, kind of activation levels, as well as socioeconomic factors like housing, education, employment, and finances. And then this is an example of a typical question from that 28 question assessment. So you can see it's pretty straightforward, and this is from the ownership dimension. And that question just reads, in general, would you say your health is excellent, very good, good, fair, or poor? And then each answer is associated with a set of points that then goes into the scoring or the letter scoring. So overall, we do know this is a very different type of metric. We like to use numbers and percentages, but as we developed this metric, we did it with patients sort of at the center, and they told us that actually letters make more sense to them. And that's why we have this letter system. It's also meant to be meaningful, actionable from a patient standpoint, and one of the goals is to reduce that asymmetry that we often have between the healthcare team and the patient team. So we want the patients leaving with exactly the same type of information that we have, so that they can empower themselves. This type of assessment lends itself easily to a next step. So for instance, if someone is scoring poorly in the physical health category, that might make sense for them to follow up with medical care. And similarly, if they're doing poorly in socioeconomics, maybe a social work consult, or in nutrition and lifestyle, maybe a follow-up with a dietitian, or in emotional health with a behavioral therapist. In our own population, those individuals scoring sort of fair or poor, which is in our minds yellow or red categories, you can see that it's not only physical health needs that patients have, but probably, at least 80% of our patients actually have socioeconomic needs that may actually even precede or trump the physical health needs. And you can see there are similar levels for other categories like emotional health and ownership. This is a couple screenshots from our EPIC electronic health record system. So the questionnaire is now built into EPIC to make it easier for the care team. And on the right side, you can see the color coding for the letter score. And again, it's a 6-letter score for those 6 categories that we mentioned, from physical health all the way ranging to nutrition and lifestyle. And in this example, hopefully we can easily see that this patient may be struggling most with emotional health and nutrition. And so especially for our complicated patients where sometimes we have trouble, either prioritizing, we may feel like there's 10 or 20 things we need to do during that encounter. This may actually simplify or help us strategize our time so that we can be more effective. And so instead of trying to do 10 or 20 things, maybe we just focus on the top 1 or 2 things in this case, like emotional health and nutrition. What we discovered almost accidentally is in our patients that were doing whole person health score assessments, they seem to be having a better patient experience. So the blue bars are those patients who have had a whole person health score, and the orange bars are those who haven't, and that's at our different clinic sites. And overall, we do see a difference, an increase in patient satisfaction. This was not the original intent, and this is not a randomized controlled trial, but it's significant enough that we want to explore that further. When we can also take this score and potentially try to use it to measure value. And this is an example where a younger male with liver problems had multiple touches in our system, including primary care, specialty care, also with our whole person care team, which is complex care for our probationers, as well as an ER visit. And we're guessing that his cost of care is at least $3,000 within our system. But you can see kind of the before and after whole person health score assessments for this individual, where they were scoring red in resource utilization and nutrition and lifestyle in January of this year, and then doing much better in July. You can actually use this assessment to also approximate or an unadjusted life expectancy for patients. And so in this case, we think that we may have actually effectively increased this patient's life expectancy from 60 years to 93 years, which would be, if we can make it stick and continue on those paths, that could be very high value for every life you're gained. Another goal of the whole person health score assessment is to create sort of a universal language or metric so that different teams and different departments can all talk about the same thing and have a similar goal. So whether you're part of the medical center or behavioral health or public health or social services, or coming from the plan side or coming from the patient side, our hope is that we can actually use one metric and one language so that we can align the work that we do together. And this is just an example of how you can also use this to compare different populations. So group 1 and group 2 on the surface for their physical health may look very similar, but group 2 may have a greater emotional health need, and group 1 may have a greater socioeconomic need. And that could actually translate into what types of additional staffing that you put in place for a given population or a clinic. And then finally, just getting to disparities, which we know is much more in the news these days, and this may be hard to read, but when we pull our data and we compare, for instance, our African American population with our white population, we see that our African Americans are scoring lower in areas like blood pressure, physical activity, smoking, but also some areas that we might not have expected, like employment. And in this case, we can actually see that if we only focused on 3 areas for our African American population, it probably should include high blood pressure, smoking, and job assistance, which might be a very different list than we normally think of. For our Hispanic population, at RUHS, we see sort of more challenges with body mass index and weight, education levels, as well as knowledge about own health. Interestingly, with our Hispanic population, they tend to outperform or outscore our non-Hispanics in almost every other measure, which on the surface may seem very confusing, because I think many of us are assuming that with a greater chronic condition load of maybe diabetes, that we would see something very the opposite. But in fact, when you look at the data, Hispanic individuals tend to live longer than non-Hispanic individuals. And so some of these factors that we're assessing in the whole person health score tool may actually help explain the Hispanic life expectancy paradox. We do see that overall for individuals getting the whole person health score assessment in our system, where we have at least 2 or more scores, we do think that we're probably lifting their life expectancy by 2 to 2.5 years. And that, of course, is not a randomized trial. And this is, very, very soft science, taking a very big leap of faith. And then finally, in trying to look at kind of ultimate value, again, we're trying to see if this type of tool can help us, even with looking at predicted life expectancy. And on the left side is using this tool, kind of what we predict for these different subpopulations at Riverside University Health System. And on the right side is the CDC data. And you can see that it's actually not that different. And we can also subcategorize by disease state or by other categories. So that may be some internal validation. So just finally, kind of as a summary, a reminder, this is a 6-letter score. It's a holistic measure of health that we use to quantify health. And hopefully, and we've been using it as a tool to help us with our teams that are growing in sort of multidisciplinary nature, and also helps us to sort of compare how we're doing across different venues and interventions. So thank you, Dr. Vercio. I'll stop right there.
Thank you, Dr. Leung. That's so interesting. I have a couple of questions for you. Sorry, I know you're trying to operate multiple different things at the same time. But one question is, how frequently do you have patients fill this out? The second question is, what's been the provider response to the whole person health score?
Yeah, so we debated the best frequency for a long time, and to get things off the ground, we've been recommending to consider doing it at least 1 or 2 times a year. In our Epic system, we're going to turn on an automatic flag for once a year. But the reality is, if you want to capture benefit from an intervention, we prefer more frequent, and especially in those individuals like where we have cases where we've got at least 2 scores. It is very nice to see, kind of an impact after a series of nutrition visits or complex care management. So, and then the feedback from our providers tends to be that, it's helpful, but as long as they don't have to take on the additional burden of having to do the assessment themselves.
Thank you so much. It's an amazing innovation. definitely could hear lots more about it, how this, what kind of team was developed to construct this and that kind of thing. So hopefully we can have you back at a later date to kind of go through that more. So we have Dr. Ariane Mitchell, which is who has developed a very similar type of idea. It's a entirely different tool, but it's focused on capturing some of the same information, but for pediatrics. So I'll let Dr. Mary Mitchell kind of introduce the whole child assessment and explain that.
Great. Can you hear me okay, Chad?
Yes.
Yes. Okay, good. All right. So I'm going to give you the very quick overview, and this focuses on the pragmatic side of how do you actually use this tool at a well child visit. So we have gotten approval for this tool to be used as an alternative IHEBA. So if you are doing physicals and using the Staying Healthy assessment, this is an alternative that you can use instead of the Staying Healthy assessment. We have developed both paper forms and then electronically available forms as well. There are part of the reason we developed this in the first place is because we were trying to figure out how to add in questions about adversity or adverse childhood experiences, but make it work with all the other paperwork and things that need to be covered at a well child visit in just a short amount of time. We have some evidence of both face validity as well as concurrent validity, where we've looked at the scores, child ACE scores, and child health problems. In terms of workflow, ideally this tool would be handed out. If it's electronically, it could be given to the families ahead of time. If the receptionist sees that it hasn't been completed electronically ahead of time, they could either give it to the patient on paper or an electronic version in the waiting room to complete. We have, in general, for age 0 to 11, that form would ideally be given to the child's caregiver, and if they are 12 to 20, it would be given to the patient themselves to complete, and then be reviewed. And so, first tip that I have is that if the caregiver hasn't completed it when you come into the room, to do the child exam first. Or in the case of the adolescent, if they are still working on completing it, to do the parent history first. And that is all for the purpose of what the heading of the slide says: use the whole child assessment to take the history during the well child visit, rather than think of this as extra paperwork that you review as a part of a separate process. This is actually a helpful guide to figuring out prioritization. Kind of similar to the whole person score in that sense, trying to help providers figure out what to focus on during the visit. And just also one little challenge, especially when we've gone to the electronic version. So often parents are getting that via the MyChart, and so you want to double check to find out who actually filled out this form. We want the 12 to 20-year-old to be done by the adolescent, but sometimes the parent does for one reason or another. So definitely find that out and use that to guide your history. So this is, the paper version. So if you get that, you may have an actual piece of paper in front of you. If for some reason it was done ahead of time, it would be scanned to the chart, and then you would find it there. And then in your EPIC template, there's the interval history comes first, and then this section for each of the sections of the WCA, where you can identify whether there was concerns or not. If you're looking at the electronic version, then you would go to the patient-reported flow sheets, and it would look a little bit like this that you see on the right. One nice thing is that it flags for you the questions that the responses were of concern. And then again, you want to review that and in your history section of your note to indicate the concerns. I want to point out that in this example, so the computer automatically calculated this ACE score, which says that there was a 1 for child ACEs, and you can see that here there was a parent or household member having a problem with drugs or alcohol. But if you look at the provider note here, right, they put no concerns. So my guess is that this provider didn't use the whole child assessment as part of the history, may have taken note of this at the end of the visit or potentially after the patient left. That's not what we want to have happen. So which is why I stress, use this form to be reviewed. If parents or families share risk factors with you, you want to make sure to take notice of that and have that conversation with them. Second piece of advice is to review the domains in order, and that allows you to help prioritize your time with families. Like Dr. Leung pointed out, we only get 10 to 15 minutes with families on a typical office visit. It's not enough, especially when big issues are brought up. And so the recommendation is first you start with that interval history. What concerns does the family has? And then you go actually to, if you're using the paper form, you go to the last page, which is safety, or if you're using the electronic, go to the end of the flow sheet, and you work backwards through that. And then that allows you, if safety concerns are brought up, you make sure to address that and so forth. The third piece of advice as you're going through and looking at which questions, this is on the paper form that you would see high risk responses on the right, or middle responses that you would want to ask about. Ask an open-ended question. And I know if you're feeling time pressured, that can often feel challenging to convince yourself to use that approach. But I assure you, it is definitely the more time efficient approach to simply ask, can you tell me more about this? Or how has this affected your child or family? That will give you the information that you need to know to figure out what does or doesn't need to be done to address this response that they gave you. And it also will hopefully help the family to feel affirmed. And that is, as we were developing this tool, one of the pieces of feedback that we got is families do want you to know about the whole picture for their child. So just a quick summary, use the whole child assessment to take the patient history during the well child visit. Review the domains in the order, starting with the interval history and then going safety and backwards through the form, and then respond to high risk responses with open-ended questions. So just before I close my comments, I just want to mention, like I said, that part of the reason we developed the whole child assessment was to integrate these questions about adverse childhood experiences, which you see listed here as family level risk factors. And the idea of being able to address those at a well child visit is because you want to use those as a springboard to talk with families about how they can build resilience in their child. And so that's the opportunity that exists. This just gives you a specific example within the substances and mental health domain of what some of those ACE questions look like. I want to point out one unique feature of this tool is that we don't just ask about what already happened, ACEs that already happened, but we ask some questions that are really more about risk of ACEs. And that acknowledges the opportunity that exists within the well child visit, not just to identify ACEs, but actually potentially to prevent them. We don't have time to go into detail here about how to counsel, but this is sort of the overview that in general for all patients, we want to use that motivational interviewing to counsel families. And when ACEs are brought up, things you might want to talk about are how to create safe relationships, stress management, and so forth. For some of your patients, they'll need a little bit more than that brief counseling, and you'll want to refer to various resources. And for very few patients, it doesn't come up that often, but occasionally you may actually need to intervene with a CPS report or other. And last tool that I want to mention that we've made available, so this is in EPIC as a smart text phrase. You can just type ACES for the English version or ACESSPA. And this basically gives you a cheat sheet of what you want to talk with families about when you are focusing on building resilience within that family. And it's a handout then that you can put in that after visit summary for the families. In addition to the description of ACEs and what builds resilience, each of the handouts have links to these different resources. Here I'm showing you the Riverside ones. There are also similar links for the San Bernardino, different, and by region, this is divided into resources that are available for basic needs, as well as substance use, domestic violence, mental health resources, parenting resources. So, and then sort of also refers families if they need additional help to Connect IE or to 211. So that's the quick overview. I am planning to do trainings on that focus on the topics that you see listed here. These are really going to be skill-based trainings to help you practice and learn how to counsel on safety, substance use, and mental health, or stress management, and more detail about relationships. All of this would sort of be tools in your tool belt, so to speak, that when it comes up, that you're able to use those opportunities that you have with families to promote health. And that's the sort of summary of my slides, and email if anybody would have follow-up questions.
Thank you, Dr. Mary Mitchell. I just have a question on, you know, what prompted your interest in this, and what did you go about to kind of develop and I know a little bit of the background on that, but what did you go about to do, or how did you go about developing this whole child assessment?
Thank you for those questions. So honestly, I would say my interest in this topic dates back to my intern year in pediatrics, where I remember seeing families for various office visits and noticing that there were differences when families came in for well-child visits that we weren't paying attention to. And I remember a little girl about 2 years old coming and climbing on my lap and refusing to sit with the mother. There was clearly something not healthy in that parent-child relationship. And but we didn't, you know, when I talked to my attendings, it was, you know, we took weight, we counseled on nutrition and exercise, and that checked their growth, but we didn't really do anything differently based on those social determinants. So that's really sort of what led to my sort of investigation into things. And when I read about the ACE study, that it just seemed to click that, okay, this is a way that we can think about family level factors that influence literally the brain development of that child and that child's future health risk, and potentially there's an opportunity we can capture at that well-child visit to improve outcomes. So that's that. And, you know, and then when I got the opportunity to be at Loma Linda and to work with you and at the resident clinic, we ran this just like it was a quality improvement project. And we started small, and we interviewed families. We asked them, what do you think of these questions? What do you think of the wording? How should we revise the wording? We got feedback from our providers as well. And then we did like just for our age 5 to 11, we started with just that group, small, revised it, and just a series. All along we sort of tracked both patient and provider feedback, as well as our rates of measuring ACEs.
Yeah, thank you. I do want to open this up to questions from any participants. You can go ahead and put those in the conversation, or you can go ahead and unmute yourself and ask the question. If anybody has any questions about either of these things. All right, so I guess we'll close out today's session. I just really want to thank Dr. Leung and Dr. Ariane Mary Mitchell, who covered these two topics. These are definitely things that we would, I think, like to see rolled out across the region because we view them as heavily impacting both children and adult health. And so if you are interested in rolling these out, I'm sure that either of our physician leads on these two topics would be interested in collaborating with you. Dr. Mary Mitchell has, as she mentioned, really approached this from the patient and provider perspective, and making sure that it was not a burden for providers and added a valuable amount of information, and also wasn't off-putting to families. That's one of the big things that that she made sure to incorporate the families so that they wouldn't be offended by the questions or would understand the purpose of the tool. So thank you all for joining us today, and hope you all have a good rest of the week.